محاضرة امبارح طلعت اتلغت. الحمد لله. دي يا أمي الحين أنا دايرة أسألك. أنا كده لسه عندي شوية. رحمة دي أبوها اسمه رحمة بالدرية. أنا شايفاه في الفيس كاتبة رحمة عصام عزب. هاي عمي. تمام.
Dilana. Este major concern. That is the Sewaji game again. The water for Charlie's organizers only. Dejani Varda. Dilla. Vardi.
Assalamu alaikum. Dear participants, we have not started yet. We are waiting for other participants to join. We will be starting in 1 or 2 minutes. So please stay in the chat and you can introduce yourself in the chat as well.
Please again. Just say that.
Hello. Am I audible, Dr. Muhammad?
Assalamu alaikum. Yes, Anas, you are.
صوت بيجي كده مرتين
Okay. Please mute every other mic. Just let me talk.
Yes, you can introduce in Arabic if most of the participants are Arabic speaking. So the session will be in English. You can introduce in Arabic if the participants are comfortable.
I prefer to introduce in English. Okay, I will start. Hello, everyone, and welcome to this very special workshop. In behalf of the Research and Publication Office at Career University, I'm truly honored to have you with us today. Here at RPO, we believe that research is not a luxury or privilege. It is a right and responsibility. That's why we aim to shape the future of research in general and medical research in particular. Today, in this extraordinary session, we will discuss systematic reviews and meta-analysis. Together, we are committed to making research more accessible and meaningful, especially for medical students and early career researchers across Sudan and beyond. Here, I'm very thrilled to announce the strategic partnership with Nibras Academy, which we honored with the founder here to present this workshop. Together, we are committed to training the next generation of researchers and building lasting bridges across institutions and countries. Before starting, we have a few important notes for all participants. Those who have the Zoom link will receive certificates of attendance. Also, I draw your attention that every question and all your questions are welcomed and will be addressed in the workshop. So let's start. And please, next slide. Next. Next. Next, please. Next. Yes, here. So let's briefly talk about the presenter, the founder of Nibras Academy. He is known for his very well presenting in systematic reviews and meta-analysis. He is a fourth year student at King Edward Medical University with extensive research and publication experience in various journals and conferences. Next. He have a lot of publications. He published over 30 full text and abstract in Q1 journals. Also, he have diverse presentation and contribution, include publication in first class journals. Also, he has a lot of conferences, abstracts. Next. Also, he have a special academy with the very recognized mentorship experience in guiding young researchers because he mentored over 100 students. And also he have experience in collaborative publication. He completed 5 publications with mentees from over all the world. And also because of this, we have this strategic partnership. Also, he have a lot of research lectures and empowering future physicians and strengthening global ties. This workshop, systematic reviews and meta-analysis, is the first step in the huge project. There will be a lot of things, the workshop and a lot of conferences in the way. So please stay tuned, and please, Dr. Muhammad, start your slides.
Assalamualaikum warahmatullahi wabarakatuh. I hope you guys are doing well. Thank you so much, Dr. Ernest. Thank you so much, Research Publication Officer for a University. And I'm thankful to all the organizers and the participants for their active participation. And thank you so much for a very brief introduction. Thank you so much. So let's start today's session. Today we'll discuss introduction to systematic review and meta-analysis. I hope you are familiar with these words, at least these two terms. So inshallah, we will be discussing all in-depth details of systematic review and meta-analysis. Our research workshop is divided into 2 days. First day would be related to introduction to systematic review and meta-analysis, and the next day we'll discuss the other portion. We will be having 1 hour presentation, and then we will take all the questions and we'll discuss all your queries. If you encounter any problem regarding screen, regarding voice, you can comment in the chat box. You can use the chat box to ask any queries. We'll be answering side by side, and we can also take the queries at the end. So let's get started. So how many of you are familiar with systematic review and meta-analysis, and how many of you have done or published any systematic review and meta-analysis? So first, let me know in the chat box. Have you participated ever in any systematic review and meta-analysis, or you have published any systematic review and meta-analysis so far? Use chat box and let me know. So that would be an interactive session besides the presentation. Yes, we have Khadija who worked on 1 systematic review. Asma, no, unfortunately. We have 2 responses so far, so we have 50-50 like, but not published yet. Yes, I'm new here and grateful. Yes, we'll start from basic. This is yes, theoretical knowledge, not practical. Isa, yes. So like you have heard about systematic reviews and meta-analysis, this is not a new thing to you. So that would be an easy, because the first lecture should be ideally on research methodology. And I assume that all of you have some extent of knowledge about research methodology. So we will be reviewing the previous concepts, and we will be reinforcing the new concepts as well. So let's get started. Bismillah. Today we will discuss introduction to systematic review and meta-analysis. As systematic review and meta-analysis is a very big paper, so it's take a lot of efforts and a teamwork. So this will explore the details and intricacies, and then you will know it's not a small thing. So that's why we have named this series as Introduction to Systematic Review and Meta-Analysis. This is a visual representation of hierarchy of evidence. You can see the meta-analysis stands at the top. So we will be learning about this. First, we have primitive cases like we have case reports, case series, case control, and other study designs. So these study designs are at the bottom of evidence, a hierarchy of the evidence. Well, they hold a great importance, but the evidence is generated and synthesized by systematic review and meta-analysis. So these are at the topmost of the evidence hierarchy because these generate one line answers, single line answers, resolve conflicts, and we'll see a lot different functions and benefits of meta-analysis. Anas has very briefly introduced me. So if you want to follow me, you can follow me on LinkedIn. You can follow me on ResearchGate as well. So discuss about significance of systematic review, the differences between systematic review and meta-analysis, and we'll identify tools and softwares that is used for systematic review and meta-analysis. We'll also discuss all the steps involved in systematic review and meta-analysis. So we'll discuss what is a systematic review. Can anyone define what is a systematic review? Yes, not finished, unfortunately, familiar or still not published. We'll discuss. Asma will discuss each and everything in the slides. We'll not skip, we'll discuss. So, systematic review is a structured and comprehensive synthesis of evidence to answer a specific question. Although we always find the answers to different questions, to curiosities that arise in our mind, and we test our hypotheses in the research. But the main thing about systematic review is its scope is very narrow. It discusses very specific clinical questions. So it does not discuss the broad questions. It has focused questions, very specific and very narrow clinical questions. The main feature of systematic review is it has a focused research question. The second thing about systematic review and meta-analysis is it has predefined inclusion and exclusion criteria. Like for other researches, like we collect data, then we analyze and then publish. That's a cross-sectional study, case control, or any experimental study. But for systematic review and meta-analysis, we formulate a research question like effects of metformin on type 2 diabetes, or metformin versus insulin in type 1 diabetes, like gestational diabetes, or anything, a systematic review and meta-analysis of randomized control trial. So we decide inclusion and exclusion criteria before doing that research. So we have defined our inclusion and exclusion criteria, like the study is fulfilling the criteria that would be included in the paper, and the study is fulfilling that exclusion criteria that would be excluded, that would not be entertained in systematic review. Another thing is that we report comprehensive search strategy. Search strategy means the search terms that we use to retrieve the articles from different databases, like you have heard the PubMed, Embase, Scopus, sometimes Google Scholar. That's not a database, it's a search engine. We have clinical trials, we have Cochrane. So all of these databases and their search strategies are reported in a systematic review and meta-analysis. So it's a very transparent and reproducible process. You have to report inclusion and exclusion criteria. Before starting a review, you have to report the search strategies for each databases, like the words, like the exact terms that you used, and the number of articles that you got from different databases. So that makes systematic review and meta-analysis a very transparent and reproducible process. Like if someone has done a systematic review in Sudan and I want to reproduce that systematic review and meta-analysis in Pakistan, I will be using that methodology. I will be using the search terms. I will be using inclusion and exclusion criteria. And I will be focusing on every component that is described by that meta-analysis published in Sudan, so that would be reproducible. It will show similar results to me when I will reproduce it here in my country. So that's the feature that makes systematic review and meta-analysis superior to other study designs. Yes, Masman. This is an example of our systematic review and meta-analysis. You can see it has a very focused research question. The research question is efficacy and safety of empagliflozin in improving renal outcomes in patients in heart failure patients with reduced ejection fraction. You can see how focused research question is that we are focusing on specific outcomes, we are focusing on specific drugs and just its specific effects in a predefined population. So you can see we have patients with heart failure patients with reduced ejection fraction, then we'll focusing on our intervention, that is a drug that is empagliflozin, and we always have a comparison in comparative meta-analysis. So these are placebo or control, and we'll focus on clinical outcomes. And what is a meta-analysis? Meta-analysis is a statistical method that combines the study data from multiple studies to estimate the overall effect or overall impacts. Like we have 5 different studies and they have same population, they have same intervention, they have same comparisons, and they have reported the same clinical outcomes. So we can combine all these studies using a certain softwares, like you might have heard about RAPMan, a review manager by Cochrane collaboration. So we pool all the results and we get a net effect or an overall effect of all these studies. So like if the different studies have different results, like it's not the case, we can never have same results of the same study that is reproduced in different populations. So we have variations in the results, but we want to resolve the uncertainties. We want quantitative effect of all these studies. We want to have like overall impact of all the studies. So it increases statistical power as well. Like if we have 5 studies and each study has 100 patients, and we have a meta-analysis and it will have 500 patients in the treatment group. So this one study has single study has a 500 patients, that increases its power and precision. And these 5 studies each having 100 patient is inferior to that meta-analysis. So we can increase the power, we can resolve uncertainties from conflicting studies. Sometimes, not sometimes, all the times we have studies reporting conflicting results. Like if a clinical trial on metformin for diabetes, type 2 diabetes on a population above 30 plus years and a specific BMI is conducted in Sudan, in Palestine, in Africa, in US and UK, all these studies, they have same study design, they have same drug, same dose, same route of administration, and same follow-up periods. But there will be different effects on each population. So what will we do in that case is we combine all these studies and we want to resolve the conflicts. We want to set the discrepancies. So we combine and we use meta-analysis. So that's what makes a meta-analysis a superior thing. So we can have a quantitative summary of evidence, like how much each study is contributing in the net effect, and where are they conflicting. So we can generate new hypotheses from a meta-analysis as well. We can explore the differences between the studies, how these studies differ among themselves, and then we can design a higher accuracy and studies that would help to shape the future clinical trials. So this is what we can take from meta-analysis. This is an pyramid of evidence hierarchy. You can see we have expert opinions. Like if you are a physician and you hold an opinion about certain disease, certain drug, and but about a certain phenomena, so you are a physician and you are expert in that, your opinion is a publication. Like your opinion about certain matter, but because it's a subjective opinion, it holds the lowest place. Like we have commentaries, we have letters to editor, we have editorials, all these things are at the bottom of this evidence of hierarchy. Then we have qualitative and quantitative studies, we have case reports, we have lab studies. We cannot apply the findings of studies conducted on animals to humans. We want the studies conducted on humans. So the lab studies hold no specific value for the patients, although they hold a lot of importance. in the clinical side, in the development of the drugs, in development of next generations of the studies, the initial experiments are always done on animals and lab cell cultures, but these findings are not reproducible and not applicable to human population. So that's why they form the basis for the clinical trials, for case control studies, and for cohorts studies, but they are not like replica of the human population. So they hold less importance in the hierarchy of evidence. Then we have case controls studies, like we can have cross-sectional studies in which we collect the data and we take the screenshot of the current time. Like we have 100 students in a class and we want to have like the prevalence of smokers in class. We'll give them a questionnaire and we'll collect the data, and then we'll analyze, and that would tell us that like the frequency, like mean, medians and averages of the smokers in the class. So this is a cross-sectional study. It's just a snapshot of the time, so it's observational. It's not clinical study, not experimental. It's hold no value. It no true value for the human health or clinical outcomes. Then we have case control studies in which we have case control studies. These are retrospective studies, like we collect the data from the past and then we try to establish the risk factors. Like if we have 100 patients, in the 100 patients in the each 100 patients, and we found that 50 patients had a positive history for the smoking and 50 patients does not have a positive history of smoking, but 75 of them developed lung carcinoma. So we have established a cause that the smoking might be a risk factor for the lung carcinoma. So this is how we establish the risk factors retrospectively, going back into the time, or the already collected data is analyzed. Then we have cohorts studies in which we have a cohort of two different groups. Like one, we have we have 100 patients in, let's suppose, in each groups, and then we'll expose to the exposure. For our case, this is the smoking, and then we'll follow up prospectively. We'll follow for 2-3 years in the future, and we'll see the risk factors, will establish the cause. So this is a cohort study. Arva will have a lot of slides on systematic review and meta-analysis. Oh, okay, okay. Khadija, if you want me to speak slowly, I can speak slowly. I thought I'm understandable. That's why I was going a little bit faster, but I will try to be in a slow pace. We have so far discussed, we have different study designs, like expert opinions. Like if you are a physician, you hold an opinion regarding certain matter, that is a publication, but it holds the lowest value in the evidence hierarchy because it's your subjective thing, that is not an experimentally established thing, so that's not uh, that trustworthy. Then we discussed that we have a case report, case studies, case series. Like if you are working as a physician in a clinical setting and you can encounter a patient with a rare presentation, like have the uncommon symptoms, and then you pursue like some uncommon treatment and have the associations that are not commonly seen. So you can publish this. This is a case. So this is not applicable to all the patients because this is just a matter of one patient and it has no study design. You are just collecting the data of a patient and reporting it. That's a case reports. After that, we have a case series. Then we have observational studies in which there is no experiment, like we just try to establish the risk factors. Like we discussed case control studies. Case control study is a retrospective study, like we go back to time, and we'll discuss that. Intihar, we discuss that. Intihar, we'll discuss, inshallah. Then we have case control studies in which we retrospectively, like we go to the already collected data and we establish the risk factor for certain conditions. And then cohorts studies, these are prospective studies, like we conduct these studies in future, like we enroll patients, divide them into two groups, and then we have one group having exposure and other group having no exposure, and then we follow for certain periods, and then again we check the data and we'll analyze and we'll see the risk factors and we'll establish these. Then we have randomized control trials. These are randomized experimental studies. Like if you want to test a drug on humans, there are study designs. These are called randomized controls trials. Like if you have 1,000 person and you want to test, we have apixaban, and you want to use this drug in the patient. So we'll randomize these patients into two groups, like 500 and 500. And the first group that would get the treatment, this is called treatment group, and the other group will get no treatment. This is called placebo, that will get the fake treatment. There will be a dummy like acting of the treatment, but no actual treatment in the placebo, so that we can actually see the impact of the drug. Uh, and we have one treatment and that other is a control. So this is a controlled trial, and we have randomized the participants into two groups, the having comparable baselines. So that is randomized, that is controlled, that has control, and it's a clinical trial. So this is randomized controlled trials. These are gold standard experimental studies. If you want to check the safety effectiveness of a certain drug, certain intervention. That intervention could be a drug, that intervention could be a surgical procedure. And if you want to do like see the effect of any exposure, this is intervention. And if you want to see the impact of exposure, you will conduct cohorts and case control studies. Ideally, we'll try to combine clinical randomized control trials in meta-analysis. Like if you combine meta-analysis, 3 or 4 trials, at least two, that would be a meta-analysis. And you combine all the data, you can see first we have the information, all the study designs till randomized control trial. This is unfiltered information. These are primary literature. We don't have appraisal. We did not filter any study. We did not perform any analysis. We did not combine the similar studies. So that hold a little value. And if we combine all these studies and filter, that would be a systematic review and meta-analysis. That's why systematic review and meta-analysis are a great thing to do. We have different types of reviews. You can see by this Venn diagram. Here are all the reviews. Traditionally, we have two reviews, like literature reviews. We also call them narrative reviews. The narrative reviews, if we narrow down this and have a specific research question with predefined inclusion and exclusion criteria, a clear-cut methodology, and we have transparent and reproducible methodology with such strategies with predefined inclusion and exclusion criteria, that review would be the systematic review. And meta-analysis is an optional part of systematic review. If you have data, if you have statistics, if you have numbers, and if the numbers are combinable and you combine these numbers, that systematic review would become a meta-analysis. So meta-analysis is not something separate thing. Meta-analysis is an optional component of a systematic review. Yes, Anas. Yes, Anas. Okay. Are you guys with me till now? Let me know in the chat box if you get some understanding of systematic review and meta-analysis so far, because this is very basic. We'll explore a lot more in details. So if you haven't get enough understanding, I can repeat all these things. Let me know in the chat box and be very active in that. Yes, yes, Sadiq. Momina. Yes, meta-analysis is an optional part of systematic review. Optional mean if you have combinable data, yes, I will describe it will come again, Dr. Arwa. It will come again. Please use the chat box and keep asking and keep telling. Yes. Yes, yes. Yes, Wala. What is this? What did you understand from this picture? So all the things that we have discussed so far, this slide is a summary. Like if we have a lot of studies, you can we have 100 studies on impacts of apixaban in atrial fibrillation, but all these studies are not clinical trials. They have case reports, there are editorials, there are narrative reviews. So what we do, we filter different studies and we combine the studies having same research question, having same population, having same drug intervention, having same outcomes. So we combine all these studies, we filter these studies. So the systematic review is basically a filter that filters the studies and combine the relevant studies to give answers to the specific question. Like all the studies giving answers to the certain research question, that would be a systematic review. So systematic review is a process of filtering studies. We can see like the scientific literature is exploding exponentially. A lot of clinical trials, like thousands of trials are published every year. These are just trials, and you can imagine the number of studies on animals, the narrative reviews, cases, like cohorts, case control studies. So the literature is literally exploding, and you can see like hundred thousands of studies are published every year. So it is impossible for physicians like us who are busy to read up all available literature on a certain topic, like if they want to prescribe a new drug. So what will they do? They will go to the PubMed, they will type, and they will have like 1000 research paper on that. So they cannot read all these 1000 research papers. So here comes our role as a researcher that conducts systematic review and meta-analysis. We read up the titles, abstracts of all these studies. Let's suppose we filter 750 irrelevant studies, and then we read the full text of these 250 studies, and then we reached the 20 studies that had same research question. So we combined all these studies. That's a systematic review, that's a filtration. So we are helping physicians, we are helping uh, guideline makers, we are helping policy makers, so they don't have to do that filtration. We are filtering the studies, and we are reporting our methodology that is very clear, that is trust, that is we can reproduce it. Yes, yes, Dr. Kadir. Again, there are different types of reviews. We have literature review. This is traditionally known as narrative reviews. It summarizes a very broad topic like cancer treatment options, like cancer-related venous thromboembolism, like that very broad research question. It is qualitative, like it does not involve numbers and stats. It is just a word explanation of the things. It may have some figures, some graphs, but there is no statistical proof. Literature review is not reliable because it may have used the sources that are biased. Like there is no methodology for literature review. You can have pick and choose. So you introduce bias into it. These studies are not reliable. You have no fixed inclusion and exclusion criteria. There is no reproducible methodology. If 100 persons want to do the narrative review on a single topic, that 100 narrative reviews would be different. So that's why narrative reviews are not reliable. Everyone can have. And then we have systematic reviews. A systematic review is a such review in which we have a specific clinical questions, like there is an example, a role of vitamin C or chemotherapy for in cancer treatment in patients over 40 years age. You can see we have strictly defined our population. We have a very fixed, very focused, specific intervention, that is vitamin C, and then we have a chemotherapy, that is a comparisons. So we have a very focused, narrow, and specific clinical questions. We have to define a specific search strategy. Search strategy means the terms that we will be using to retrieve the articles from the databases. And then we have to give inclusion and exclusion criteria. Uh, and then comes the meta-analysis. That's an optional part of systematic review. We combine the similar data to get the statistical results. So if there is a data and that can be pooled or combined using different softwares and to give a single line summary results, that systematic review would be a meta-analysis. Clear? Let me know in the chat box if you're clear with different types of reviews so we can move forward to the next slide. Yes, Momina, clear, Basma, Surosh, Fatima, Jazakallah. The yes, yes, it's all right. Thank you so much. So let's move forward. Again, there is a difference between systematic review and meta-analysis. We have a lot of queries. What's different between these two? So a systematic, as I told earlier, meta-analysis is an optional part of systematic review. Systematic review is a qualitative thing, like it does not involve stats and numbers, and the studies can be heterogeneous. It means that we can combine the studies, folks having some differences. We can explore the heterogeneity. Heterogeneity means how these studies are different. So it's a quantitative thing. Meta-analysis is a quantitative thing, and systematic review is a qualitative thing. So if we want to give the quantitative results, the results in the numbers, maths, that's a meta-analysis. We quantify the effects. We quantify the effect of each study. We quantify the differences. We quantify the biases. So everything is quantitative in meta-analysis. So here comes a question for you. Let me know in the chat box first. How many clinical randomized control trials are published every year? That could be a guess. I don't expect the correct answer. I just want to see how many randomized control trials are published every year so that we can have an idea why we are focusing so much on combining these primary studies. How many thousands? Like we have an answer thousands. Basma said we have thousands. How many thousands? One randomized control trials, three at least, 100, 2 to 4, 1, 2,000, large numbers. Any guess in thousands? It's not in hundreds, it's in thousands. I want a guess in thousands. These are just randomized control trials. There are other study designs as well. 10,000, 1 lakh plus a large number. So we have so far 19,000 plus randomized control trials are published. Other study designs are separate, like editorials, case control studies, case reports, narrative reviews, cohorts. So these studies are beside. So we have a lot of studies, thousands of studies are being published every year. That's why we need systematic reviews and meta-analysis so that we can filter out the similar information and combine them into a single paper and to give a single line answers. Like as a physician, as a policymaker, they don't have enough time, they don't have enough energy. Humanly, it's not possible. Like if you have 100 clinical trial published on a single disease, that would be humanly impossible for you to read up all these clinical trials, then analyze them, and then critically decide the intervention for your patients. Here comes us, we 15 million ream. Momina, at least we need at least 2 or more trials to do a systematic review and meta-analysis. This is according to Introduction to Meta-Analysis book. Here is another question for you. I'll leave you to answer this. We have 3 clinical trials, trial 1, 2, and 3. We have number of patients like 1,500 and 100 patients. We have only Asian and blacks, and then we have only blacks. We have that paper was published in 2005, that was published in 2022, that was published in 2023. There are some certain properties of these trials. First trial is not randomized, not blinded, but it follows the guidelines of that trial. We have randomization, we have blinding, we have consort guidelines. So as a physician, can you decide which drug would be favorable? We have 2 drugs for the same population, same disease, drug A and B. So which drug would be beneficial in that case if we have 3 trials having conflicting results conducting in different years? I want reasons for that as well. B, we have drug B is better. How drug B is better? We have big sample size, we have blinded and randomized, so bias, there is less bias. All our track depend upon including and excluding criteria, randomized patients and blinding. So any of the reasons has 2 more steps and it's less biased. Okay. What if as a physician I have to decide between 3 clinical trials? So my approach would be combining all these randomized controlled trials, all these trials individually, like it's conflicting for us to consider these studies. Like we have one study that's latest published in that it's favoring drug A. This study has less number of patients, but it has a broader population. So every study has a certain, like this study has 1,000 patients, and but it's published old and it does not comply with these things. So we have like pros and cons of every single study. There are differences in that. We have some studies saying drug A is better, some drugs saying drug B is better. So when there are conflicting results and we want to see the impact of the overall impact of the drug that would be effective. So what if we combine all these clinical trial and do a meta-analysis, we will get the results and we can resolve this discrepancy. Ideally, if all the trials followed blinding randomization consort guidelines, so that would become very difficult for you to decide which study is going to be the best study, not just from looking at the year of publication. So here comes meta-analysis. If we have all the studies complying to randomization, complying to blinding, complying to consort guidelines, and they have different population and different number of patients, but they are published in different years. So that's why we combine these studies and we want net effect. We want single line answers. We want which drug is effective. So as a physician, I will I will not go into that details, and we'll look which study is better, and then we'll decide based on the patients. So we'll do meta-analysis and we'll get the answer which drug is better and why the drug is better. Yes. So so far we discussed a lot of features of meta-analysis. There is another query for you. Why conduct a meta-analysis or systematic review? We have discussed a lot of reasons. I would like to hear from you. To build a guideline evidence-based man to make a big statistical power, yes, Momina, yes, Sadiq, yes, Basma Mansoor. Yes, anything else to answer a question based on evidence? Yes, Isha. Yes. Anything else that meta-analysis could do? Summarizing the results of multiple RCTs? Yes, Amar. Yes. Excellent answer. That's it, Idris. Provide conclusion about interest, topic of interest. Yes, Khadija. Idris, yes. Reducing time, reducing bias. Yes, Amar. Excellent. Excellent. So far you are with me and you're getting a lot of to resolve the conflicts, one of the most important thing. Yes, Sulafa, meta-analysis, uh, helping WHO for establish guidelines to update or build guidelines, combine multiple RCTs to emphasize, facilitate reaching the right information. Yes, exactly. We do that. We answer specific questions. We want to help them building guidelines. So we first thing is that we want to compile the informations. Like as a physician, as a scientist, we don't have enough time, enough energy, and humanly it's not possible to read up thousands of articles and then get to the right conclusion. So we want information in compiled form, so systematic. So are the systematic reviews there. We want single line answers. We want to resolve conflicting results. And we want to practice evidence-based medicine. It helps to change the policy, and we identify new research gaps as well. So how we'll identify new research gaps? Like we have 5 clinical trials and we have 2 drugs like drug A and drug B. And we did a meta-analysis and we found that neither drug A nor B is effective for certain population. So why we are investing a lot of money if on macro level there is no difference between these two interventions? There is no difference between the treatment and control. So we can identify research gaps. We can modify the future clinical trials based on that. Evidence-based healthcare, yes, now, yes, Idris. Exactly. Excellent, guys. You're doing amazing job. What are the key features of systematic review? It has again, this is a summary. So we'll moving towards the next steps of conducting systematic review. A clearly stated set of objectives. We have predefined inclusion and exclusion criteria that reduces bias. Then we have explicitly reproducible methodology. Like we discussed that we have to report the search strategy, the terms used to search specific databases, the number of articles retrieved, then the process for screening, then reasons for exclusion of certain articles, then the whole process for the analysis. We'll have to provide the systematic search, and there would be a quantitative assessment for the risk of assessment. It means that we'll quantify the things that are like we have that specific tools to assess the quality of the studies and to detect the defects in the studies that are inherent in the included studies. So if we are pulling poor quality studies, our meta-analysis would be of poor quality. If we are pulling good quality study, like earlier you saw a slide having different conditions fulfilled by a clinical trials, but you were favoring trial 2 because it was fulfilling certain conditions, certain requirements. So whenever a trial is fulfilling these conditions, it's a good quality. And if we have biases in the trials, that is of poor quality, and if we include in our study, that would be of poor quality as well. And yes, move forward. What are benefits? We increase statistical power, improve the precision, and ability to address inconsistencies. We have discussed these things already. Ability to answer new questions, so we can explore new relationship between study characteristics and outcomes. As I gave an example earlier, that if two drugs having no superiority, they are not superior, not inferior. They have no difference between two groups in 5 clinical trials. So we'll modify our population, modify our doses, and we'll modify the future clinical trials based on that systematic review and meta-analysis. So here comes some limitations of meta-analysis as well. What did you get from this picture? Yes, yes, Momina is fast. Now I have different types of studies, different results. Safa said we have different results, combining different studies. Mohammad Isai as well. Guess included studies must have same area of interest. Tibian combination, blinding between different studies. Uh, any other guess? So you're right. This is like we are combining apples and oranges. This is a well-established phrase about the meta-analysis intervention. Like we can combine all types of studies, but that would make these things that would become a pickle-like thing. We cannot combine apples and oranges. We want to combine the studies having same population, same intervention, same outcomes, and everything is same. So same or similar means they are like everything is same. So that would be more impactful studies. In meta-analysis, you can combine different studies that will introduce heterogeneity in your meta-analysis. Heterogeneity means the differences in the results. Like that could be from the poor methodology, that could be from the poor patient selection, poor randomization, etc. Here is another thing with a great phrase, and I want your attention and your comments about that as well. What's that? What did you get from this phrase? No, it's not very hard. We have a lot of, as I have told you earlier, that we have 20,000 plus clinical trials conducted every year. We don't have 20,000 different diseases, nor we have 20,000 different drugs every year. It means that a lot of clinical trials are conducting on same population and same drugs. Oh, yes, Hannah said poor quality studies give poor quality results. Yes. Momina, as if it's filtering the research gap. No, 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 that's not the case, Momina. That's wrong. Fatima, exclude not relevant studies and filtration of biased data. It means that if we combine poor quality studies, our meta-analysis would be of poor quality. Like if we put all the garbage, we'll get garbage in return. If we put high quality studies, we'll get high quality meta-analysis. And if we put all the garbage into our meta-analysis, that would be of poor quality. We might have very good results, positive findings, but due to poor methodology and poor study selection, that would be of very poor quality. So we don't combine these studies if there is a quality issue, there's appearance biases in the methodology of these studies. So the garbage in and garbage out should be remembered. Then we have another thing, that is heterogeneity. These are apparent differences between the studies. Yes, Sandra. And we have a smart depend on studies that you choose. Yes, yes, Momina. Exactly, it is. So if we have all the studies having very good results and certain studies that introduces heterogeneity to our meta-analysis, means the difference, means the deviation from the results, it can ruin the findings. So heterogeneity is one of the major drawbacks or limitation. But we have certain skills, methodologies, so we can reduce this bias. We can reduce the heterogeneity. So here is a summary for that. If we combine poor quality studies together, the meta-analysis would be of poor quality. And if we have a publication bias, like we have included studies as per our wish, not adhering to pre-specified inclusion and exclusion criteria, that would introduce a potential bias in your results. Like you are not following your inclusion exclusion criteria, you are not sticking to your research question, it results in a publication by you are like you have chosen certain studies to be included in your meta-analysis. So if you do that, that would be detected in a meta-analysis, and that would be a quantitative thing. Like you will see the heterogeneity value, the percent of heterogeneity, and then if you see the studies contributing heterogeneity, you will see these studies have differences from all other studies. And then heterogeneity variation in effects across the study, it means that how studies are different among themselves. If studies are different, they will contribute to heterogeneity. So what are different steps in conducting a systematic review and meta-analysis? Uh, we'll discuss first four steps today, inshallah, and we'll discuss the other things in the next session. We take the questions after that, and we'll continue the next four steps in the next session. So what are different steps conducting systematic review and meta-analysis? Yes, the same link will be used tomorrow, inshallah. Firstly, we'll define a research question. There are certain frameworks for defining a research question. Then we'll develop a protocol. We'll conduct a literature search from different databases. We'll select the studies based on the inclusion and exclusion criteria. So we'll discuss these four things today. So what about the topic selection? Topic selection is a single most crucial steps. Is it like it's the first stone, it's the first brick. The topic, there are certain things that should be considered while choosing a topic, that the topic should be novel, the topic should be interesting, and it should be clinically relevant. Like you cannot choose topics related to COVID-19 in today's world because it's a gone thing. So the topic should be novel, it should be clinically relevant, and it should be interesting. Here is a question for you. Allahu Akbar, how cruel are you guys? You are rejecting a paper. There is no single yes from a single person. You guys are very cruel, and you have like stone in your chest, not heart. So can you please give me the reason for rejection as well? Why did you reject a good paper that has a very excellent search strategy, data extraction, and write up? Everything is perfect, but you are rejecting it. Revised by code strategy. Patrick said we should revise the anything else. I want to listen the exact things. Neither it's relevant nor it's interesting. Like smoking is a very interesting thing. Everyone enjoys doing. You are using your like Yes, exactly. This is the thing, the most crucial thing in publishing an article, that editors see the novelty in thing. Smoking as a risk factor for lung carcinoma is not a it's a clinically relevant, it's an interesting topic, but it's not a novel topic. Smoking is an established risk factor for lung carcinoma. Uh, Years ago, like 50 years ago, it's now established. It's not novel. Novelty is one of the most important things. So always think something novel, think something that's hot today, like AI is hot today. So if you do something to relate it to AI that would have a more chance of publication, then you are doing a smoking as a risk factor and other things that are thing of bygone days, and that's not applicable in today's world. That is already established fact. Smoking is no more hypothesis. It's an established fact. If something has been established, so it's not required today, so that will get a straight rejection. Yes, Khadija, all the things are correct. Allahu Akbar. So, how will formulate a research question? Like everything, we have standards for formulating a research question. How will we formulate a research question? We have like we'll follow the PICO or PICO criteria, in which P stands for population, I for intervention, C for comparison, and O for outcomes. So every research question should have four these essential components of the systematic review. You have to define your population or patient or your problem. Like I've shown you an example of efficacy and safety of empagliflozin in renal outcomes in patients with heart failure with reduced ejection fraction. So my population is heart patients with reduced ejection fraction. So we have defined this. I will define what is meaning by the reduced ejection fraction. So everything is defined and everything is fixed and focused. Then comes the intervention or exposure. Intervention stands for anything that is drug or any surgical procedure. So this is intervention. Will combine we'll see what do we do to them. In clinical setting, we are always dealing with drugs. We are always dealing with surgical procedures. So we want to explore the superiority of certain procedures, certain interventions. So intervention is a drug or a surgical procedure, and then we'll make comparisons. If we have two different techniques and we want to see the superiority, like the comparison of two techniques, two drugs, two surgical procedures. So we'll set up a comparison as well. Sometimes that control could be the placebo. It means that we are comparing a drug with no drug, and what will happen to the patients, what will get. These are the outcomes. We are always struggling with doing these studies to have a better healthcare outcomes and to establish the evidence-based practice. So we will focus on clinical outcomes. Again, there is a visual representation. P stands for the population, I for intervention, C comparison, and O outcomes. And sometimes we may have a time limitation like follow-up periods, etc. as well. So there are certain steps in selecting a topic. How we'll get into selection of the topic. So we'll select the area of interest first. The main thing is like the funnel theory regarding that. We start from a very broad thing and we'll go into the narrow thing. So we'll start by the area of interest. Like if you want to be a cardiologist, the cardiology is your area of interest. Like me, I want to become an oncologist or hematologist, so that is my area of interest. We have to identify or select area of interests. Like if you want to become gastroenterologist, a gynecologist, or anything that's your area of interest. So you'll select your area of interest, and then you'll select the disease. We'll see the certain disease that have a global prevalence, a lot global burden, and a lot mortality these days. So you can select a disease from your area of interest, and then you will start reading all available treatment options. As the meta-analyses are commonly done on randomized controlled trials, so we'll read all the available treatments and will select a treatment like a new drug approved 5 years ago, and it has a 5, 6 clinical trials on same population, and there is no meta-analysis, so we can do a meta-analysis on that. So this is how we'll select a topic. We'll start from a very broad thing, and then we'll narrow down till we get a topic. We'll select from area of interest, then we'll select a disease, then we'll read up all available treatments, and we'll select a treatment. And then we'll find the gaps. We'll check if a meta-analysis is already conducting on it or not. We'll formulate our research question. We'll define our population. We'll define intervention. We'll define our outcomes and comparisons. And if it's a feasible mean there are plenty of clinical trials. There is literature available on that, but there is no systematic review and meta-analysis. So you can do if it's feasible. If it's not feasible, then you'll move again towards this, and then we'll go to the process again. We'll search the literature and start. So what's an area of interest? Area of interest, that's something aligns with your research interest, having certain clinical significance. It's related to stakeholders like the users of systematic review and meta-analysis. These are patients, clinicians, and policymakers. You might have heard about the guidelines by American Heart Association, guidelines by American College of Gastroenterology, like guidelines by American College of Cardiology, American Heart Association. So all these policies, all these guidelines are a result of systematic reviews, and then these guidelines help patients get evidence-based care from clinicians to have lesser side effects and have greater safety and greater effectiveness of certain treatments. So that should be relevant to the stakeholders. Mentor is readily available. The availability of mentor, I think, is the most important thing. Systematic review is a big thing, and you need a certain mentor that is available, that's available to guide you on every step. You will face a lot of difficulties, like you can manage the team, can decide the topics, and can allot the tasks to the team, and then can check the work of all this and guide on every step. So that's also an important thing while selecting an area of interest, the field you want to pursue. And the most important thing, a lot of new clinical studies are being conducted on that. That could be cardiology, neurology, gastroenterology, oncology, and hematology. So I'll discuss an example of cardiology. I'll select a topic in cardiology. I'm interested in cardiology and I want to become a cardiologist. So I will see, I will read about the different diseases, like I have coronary heart disease, arrhythmic, valvular aortic, and heart failures. I have different kinds of heart failures, different vascular disorders. I read about that, but I'm interested in heart failure, and I'll started reading different treatment options, like I have ACE inhibitors, ARBs, we have beta blockers, sodium glucose transporter inhibitors, diuretics, digoxin, and we have many other choices, but I'm interested in a sodium glucose 2 transporter in heart failure. So then I came to know that there are certain different classes of that. There are empagliflozin, empagliflozin, and certain empagliflozin in that. So I saw that there are a lot of clinical trials on these drugs, but I am interested in specific role of empagliflozin. So here comes how I perform, make my research question, safety and efficacy of empagliflozin in patients with heart failure with reduced ejection fraction. So this is how we narrow down and we get into the topic. So similarly, you can get into that and decide your own topic. We have another example, safety and efficacy. You can see we have a patients with reduced ejection fraction in empagliflozin. And so the next step would be, after we have decided a topic, we'll develop a protocol. Protocol ensures transparency, It's similar to institutional review board or ethical review board approval, but meta-analysis does not require any approval. This is just a blueprint of protocol is a blueprint of your meta-analysis, like the strategy. How will you conduct this? This is not simply a roadmap. This is not a required thing, but it's a recommended thing. If you don't uh, register a protocol, that's not a compulsory thing. It's okay. A protocol basically means what you will do in that meta-analysis, how will you search the databases, how will and do the analysis. Like it's a roadmap for your review. Objective search strategy, including excluding criteria and data extraction and analysis method. You will state that you will decide beforehand so that you can work on this. There is International Prospective Register of Systematic Reviews. This is called Prospero. You can visit their websites. You can watch the videos on that. Like you can register your systematic reviews and you can put this registration number in your manuscript. So that makes your paper more impactful, that you have been sticking to the Cochrane guidelines that are official guidelines for conducting systematic reviews and meta-analysis. Then we'll search the literature. I will show you meta-analysis paper tomorrow, and I will let you know the search strategy. I will search all the databases. If we have time, we'll try to search one or two databases as well. For today, we have different types of databases, like we have PubMed, we have Cochrane, we have Scopus, we have Embase, we have clinical trials, Web of Science, and then the most famous Google Scholar. But Google Scholar is not a database, it's a search engine, because there is no specific search strategy for searching that. There is no indexing. There is a lot of gray literature. That means unpeer reviewed, non-peer reviewed, or compromised literature here on Google Scholar. So we have these databases. PubMed is free, Cochrane is free, clinical trials is free. Others, these databases are not freely available. So if it is recommended according to Cochrane collaboration to at least search 2 databases, but usually we can search 3 or 4 databases. We can have like 95% literature in our meta-analysis if we search all these databases. Then we'll screen all these articles. Like we searched 3 databases, and I got 750 from PubMed, and I got 350 results from Cochrane, and I got 300 results from the other databases. So that's like 1400 plus articles. All these articles are not similar, are not relevant to my paper, but they might have some terms that might have common in our topic. So what we'll do, we'll move towards the next step. We have identified different articles from 3 databases. We have 1400 plus articles. So what we'll do, we'll start screening them. First, we'll remove duplicates. As we have used multiple sources, there might be some articles that might be redundant or duplicate. So we'll remove the duplicates. Like we have searched 3 databases, quite possible we may have more than 300 articles, 400, 500 even articles that are duplicates. So the first step in screening would be deduplication. We'll remove the duplicates, and then we'll screen the remaining articles. Like we have 1000 articles. We'll screen on the basis of their titles and abstract. We'll just see the title. If title has overpopulation, over intervention, we'll confirm yes, and we'll include it. Otherwise, we'll exclude it. Like we have 700 articles that are not relevant to our PICO criteria. What we'll do, we'll exclude all these studies. Now I have 300 studies. These are a lot more. I will try to retrieve their full texts. Like the 100 studies don't have full text. So I will exclude these studies as well. Now I have 200 studies. So I will get their full text, read their full text, and I will include potentially relevant studies. You can see I have reached 30 studies that are relevant. Like I can have less number of studies, like 7, 8, 9, 10 studies, more than 2 that are enough for our meta-analysis. So these are the steps. How I'll screen. We have deduplication in screening. We'll remove the duplicates. Then we'll do primary screening. We'll focus on titles and abstracts. And then the studies fulfilling this criteria will that get into the secondary screening. We'll check their full text. If full text are available, we'll check against our inclusion and exclusion criteria. If they fulfill our inclusion exclusion criteria, we'll include, otherwise we'll exclude that. So this is about screening. Will follow our inclusion exclusion criteria. It is recommended to be done by at least two reviewers to resolve the discussions by the third independent reviewers. So what are different tools that can be used for screening? So here are certain tools. You can see we have Ryan, we have Zotero, we have EndNote, we have Excel, and we have Google Sheets. So Ryan is an excellent tool. It's a web-based AI tool. So a wonderful tool for screening. We have a Zotero, that's a reference management software, but we can use it for screening as well. Then we have EndNote. Then we have Google Sheets. These are the old days methods, and we'll have these. Ideally, I use this for primary screening. Ryan is very excellent for primary screening, and I do secondary screening on Google Sheets. Tomorrow, I will show you the samples of the primary screening, the secondary screening, the data extraction. I'll do the analysis. We cannot cover all these topics because training is a single topic that requires 2 hours. And the literature searching all the databases require another 2 hours. So this is a whole big thing, and inshallah we are hopeful to collaborate with RPO, we'll collaborate with the university, we'll collaborate with the dental alumni, and we'll try to cover and convey these topics to our brothers and sisters there in Sudan as well. I think we'll stay here today, and we can discuss the other things tomorrow. I'll try to take the questions. You can you repeat the point of topics American of which Fatima we have? Can we have this? Yes, of course, Ashma, you can have this presentation. Idris, yes, yeah, Idris, you can listen again because inherently it's difficult for me to speak slowly. Sometimes was in a flow. I start like in a speed. Ryan is yes, yes, Khadija, Ryan is a perfect tool. Yes, Basma, thank you so much. You're so sweet. As Amar, inshallah, has that ended from Incent, Asma. Thank you for fruitful information. Wait, inshallah. Thank you so much, Dr. Fatima. We'll have, should the protocol be shared last week after finishing systematic review before? No, we can have our protocol shared at any stage of our review, but it's recommended to have at least when you are like uh, just starting your search strategy. When you are done with checking the feasibility of your topic, and then you have made the search strategies, you have searched the databases and you have defined the outcomes and the analysis scheme, so you can register the protocol. Thank you so much, Sandra. Siddiq, how to check viability on Prospero? It's another topic. Thank you so much, Faiza. Basma, I'll discuss these things. Basma, the one of the good thing, like one of the easiest thing to find the relevant ideas, is to explore the journals. Like we have New England Journal of Medicine, we have JAMA, we have BMJ. We have a lot of journals that publish randomized control trials weekly, fortnightly, or I think monthly. So just subscribe to their alerts, email alerts. I myself have subscribed to their email alerts, and then you can read up the latest randomized control trials published there. The trials could be a ready-made topic for you. You have just to check that trial on PubMed on Google Scholar. If there are other related randomized control trials that you are reading in New England Journal of Medicine, in any journal like if there are certain other studies, that's a good way. Like it's a ready-made topic for you. Thank you so much, Ahmed. Thank you so much, Nada. You're so sweet. Inshallah. Inshallah.
Hi, Dr.
Thank you so much,
Muhammad.
Momina, Sulafa. We have Nahul, Dion. Thank you so much, Patrick. Thank you. Thank you so much.
Can you hear me, Dr. Muhammad?
Assalamu alaikum. Apologies for that. I got disconnected from the internet. Can you please hear me? Let me know if you're audible. And unfortunately, I have lost some previous questions. No, I got that. Thank you so much.
Dr. Muhammad, can you hear me?
Yes, yes,
Am I
yes.
audible?
Yes, Anas, you are audible. Thank you so much. And apologies for the internet issue that I got disconnected. So I think if you have any questions that you can post it here. You can post your queries. I'm here to answer. About today's session, we'll discuss a lot more things tomorrow, inshallah, at the same time. I think we have no more.
I have some questions from YouTube.
Yes, yes, Anas, share please.
Firstly, how many RCTs needed for systematic reviews?
We need at least 2 randomized control trials to do a meaningful meta-analysis. Like a meta-analysis with 2 trials, 2 studies is better than a single study, single trial. So some seniors, some experts says if you have at least 2 studies, you can do a meta-analysis.
Okay. Also, there are another question. Does using RCTs with overlapped data source and set can affect my quality of systematic review?
Can you please repeat the question? I did not get that.
Does using overlapped data set in RCTs can affect the quality of my systematic review?
Yes, of course, it affects your quality. You cannot include the same trials for two, like the trials describe the data they published at the different intervals. So we'll choose the latest data set. You cannot duplicate the data set for a single study. Like the same patient, the same drugs, but the results are published at different intervals, and like we have certain secondary analysis of that trials, so we cannot include these studies. That would be a duplication. So if you include a trial two times, that's a mistake. It's not recommended. It's recommended to include the study, include the randomized control trial with the latest information.
Okay, perfect. Also, there are another one inquiring about the meaning of placebo.
Placebo means the fake or dummy drug that looks like drug, smells like drug, tastes like drug, but it does not contain any drug. Anything that mimics a drug is a placebo. Like if you want to check the safety and efficacy of metformin, so how will you compare that with no drug? So there is an effect that's called placebo effect. Even if you're not giving drug, there might be some beneficial results in that patients. So if you want to compare a drug with no drug, you will give a dummy drug to the control and the original drug to the treatment group. That would be like that blinded. It means that nobody will know which group is taking the drug and which group is taking the placebo. So we'll get the results without any factors that could affect the results, the findings of the drug. So that gives us more precise like idea of the safety and efficacy. So in simple words, placebo is a thing that looks like a drug, tastes like a drug, smells like a drug, but it's not a drug. It's a dummy or fake drug.
Okay. Also, there is another question inquiring about what are the criteria that make my systematic review question an idea is valid?
So the first main thing is that it should be novel, it should be clinically relevant, there should be at least two randomized control trials on that topic, and there should be no meta-analysis on that topic. So if there is a meta-analysis already published on that, that's a repetition. So you need at least two studies having same population, same intervention, same comparison, same outcomes, and you combine them, and there is no repetition, there is no previously published systematic review and meta-analysis, and they have same population as per the definition. How will you define your population? Like some papers may contain different definitions, so you'll define to include maximum number of relevant studies. The ideal thing for systematic review on an idea is that there should be a sufficient literature available on that, and ideally no systematic review and meta-analysis published on that, because we want to do something new, novel.
So can we conduct a systematic reviews in order to update existing one?
Yes, we can do. If we have new studies, we can update systematic review. This is one of the greatest like features of systematic review, that they are not static, they could be updated. Like if a meta-analysis is published in 2024 and it has 5 studies, and there are 2 more studies that are published in 2025, so you can add these 2 studies to that first study, then that would be a new meta-analysis, that would be an updated meta-analysis. So you can update meta-analysis anytime.
Okay. So is there any sources for already protocols in my topic? If I'm conducted a systematic review, is there any existing protocols?
Yes, you can check these already existing protocols from Prospero website. You can search the topic. If you have a certain research question and you want to check if someone has already registered a protocol or not, simply go to the Prospero website and search your topic. You'll see if there is any registered review on your research question. You can change your research question so that your work is not going into vain.
Okay, is there any tip or trick that make screening more easy?
Oh yes, there are some certain tricks. Like first is that you can use Rayan is an excellent tool. You can remove the duplicates and then you can add the tags. That would make your easy. There is basically color coding. If there are certain keywords that are added to the included, the that words would be highlighted in green in Rayan. And if you add certain words that are excluded, so you can that would be highlighted in red. So the color coding will help you just see the color coding. The greater color, if there is a all green, it seems that all your keywords are in the title and abstracts. So that's like make the thing very easy and fun as well.
Okay. If I didn't find any RCTs in my topic, shall I use courts and cross-sectional studies?
Yes, you can use. You can use case control studies, you can use cohort studies, you can do a single arm or proportional meta-analysis on cross-sectional studies. So meta-analysis has some types as well. Like the meta-analysis that we traditionally do is called comparative meta-analysis, in which we have two groups, but on we ideally we do on randomized control trials because they have higher superiority on in experimental studies. We want to do studies on that are of highest quality. So the gold standard studies for human are randomized control trials. That's why we do that. If there are no randomized control trials, we have observational studies, including case control and cohorts. We can do on that. And if we don't have case control or cohorts studies, like certain studies that have, like we have studies uh, on the prevalence or the proportion. So we can combine all these cross-sectional studies as well. This is called single arm or proportional meta-analysis. And if you have multiple drugs if you want, and you want to compare all these, this is called network meta-analysis. You can do network meta-analysis. You can compare 5 drugs together, 6 drugs together, 10 drugs together in network meta-analysis. And if you don't have any control arm, you have just treatment arm, you can do a single arm meta-analysis, you can do a meta-analysis of cross-sectional studies. This is called proportional meta-analysis.
Okay. Also, using non-randomized clinical trials can affect my systematic reviews.
Of course, it can affect, but you can have a strong justification for inclusion of non-randomized studies. It's discouraged to combine randomized and non-randomized studies because they influence the quality of the outcomes. So if you have randomized studies, go for that. But if you don't have so much randomized studies and you have non-randomized studies, you can include, but you have to give a strong reason for the inclusion, like there was scarcity of data and and you discuss the things that could have affected your results and you acknowledge your limitations, so it's okay, you can and you can perform. If there are no randomized studies, you can do a meta-analysis on non-randomized studies.
Okay. If I'm searching in a specific topic, but I didn't get any of the RCTs unless in not English language or specific in Chinese. So shall I include it in my systematic reviews?
Yes, it's an age and era of AI, so you have a lot of translators. You can simply use the translator if scientific meaning is not distorted. If there is a preservation of scientific meaning, you can use the translation. You can rely on translation. If not, then it's encouraged to include only English studies.
Okay. I don't have any other questions.
Okay, that's all. If anyone having is more queries, can post in the chat box. Thank you so much, Safa. Thank you so much, everyone, for your patient listening. Thank you so much, Anas, for your collaboration, for your companionship, and for hosting this. If someone has any queries, you can Anas, you can forward it to me on my WhatsApp, and I'll take these queries before the next session. That's it for from my side. And thank you so much for your patient listening. Take care and Allah Hafiz.
Okay, thank you, Dr. Muhammad, for this extraordinary and comprehensive session. All questions will be directed to your DM in WhatsApp, and there is no questions. And thank you very much.
Thank
We
you so
draw
much.
your attention that the session of tomorrow will be at the same time,
Inshallah, inshallah.
inshallah.
Jazakumullah khair.